Well, why have we decided to come along today and hold this event here? The idea came from our annual Healthwatch Norfolk live event, more of which later on, which we hold every autumn in the Forum in Norwich. It's a similar event to this, and it acts as a gauge of what is going on across the county when it comes to health and social care. We wanted to make sure that we continued to embed our roots in the varied communities across Norfolk as much as we can. Where better to start than here in Galston, almost the easternmost point of this wonderful county. Our engagement team work extremely hard talking to people at GP surgeries, pharmacies, chemists, community centres, libraries and events right across the area, finding out what is working for you and what isn't. We can then feed this back to the people that make decisions about health and social care. It's also important that we tell you about what we and the wider health and social care network are doing. That's all part of what today is about, making sure that you are informed about things that are going on in this area and where you can get help and support. During today's event, you'll be getting an update on the future of the James Paget Hospital from some of the people on my left, and how you can play a part in making sure that your views help to shape the future of healthcare there. Palliative and end-of-life care can often be difficult things to talk about. Communities are doing a lot of work to help with this, working together at what is a challenging time for many. We'll be hearing more about that later. And the role of carers is something that we hear a lot about. The help that is out there, offering extra support, will also be highlighted later today. We'd really like you to stay after the presentation, network with the many organisations and groups here today, and you can share your feedback with us too. Shortly, Healthwatch Norfolk's Chief Executive, Alex Stewart, will give you an insight into our work over the last 12 months. But first, a brief film filmed and created by an up-and-coming filmmaker, Jaden Johnson, who lives about 10 minutes from here, who we asked to explain in a couple of minutes what Healthwatch Norfolk is. And this is what he created.
The organisation listens to the views of any resident in Norfolk about their experiences of any health and social care that they may have experienced. So it could be going to visit your general practice, it could be having somebody come into your home who's providing some form of domiciliary care, or it could be a social worker who's dealing with your relative who's got some form of dementia. We cover from pre-birth to death, and it's the whole of health and social care. Yeah, and we are able to actually evidence that we have made changes, or changes have happened as a result of Healthwatch interventions. Since 2013, we've undertaken about 90 discrete projects, and out of all those discrete projects, there have been a minimum of 3 recommendations, and we've cross-referenced those as we've moved forwards and can show that the changes that people have asked for have happened.
I don't really know how to follow that thing, because I was in that as well. But for those of you who don't know me, my name is Alex Stewart, and for my sins, I'm the Chief Exec of Healthwatch. My job is actually quite a fascinating one, and I couldn't actually do it without the really absolutely amazing team that I have who surrounds me, many of whom are here today. So this is yet another opportunity for me to actually personally thank them. Their knowledge is phenomenal, so please use their brains and their intellect and question them and quiz them, because I'm afraid I'm going to be escaping after this to go to King's Lynn. So they are my ambassadors who do an incredible job, as well as do our trustees. I just want to do a quick overview of the last year. So I thought, what better place to start than with the numbers? We had 2,649 reviews, 511 inquiries, and the team wrote 56 reports, which is obviously over one a week. The issues we heard most about, more than anything else, was obviously dentistry. It still remains a huge problem. Over half of our inquiries have related to difficulties accessing non-emergency NHS dental care. And as you will see shortly, it's something we have been raising at a local, regional and a national level. That said, it's sadly not in our power to increase the amount of NHS dentistry, but we will do all that we can to lobby and fight for Norfolk. We had representation earlier this week as a Health and Social Care Select Committee in the House of Commons, and we're represented by our colleagues from Lincolnshire. All the feedback we receive is valuable as it helps us to plot exactly what is happening and where there are deficiencies. I would also, at this juncture, like to take the opportunity to actually highlight the work of the locally based plumbers' dental practices, whose Little Smiles work we have highlighted at a national level. For teaching young people the value of oral health, a vital tool to help future generations. Mental health, people will be aware of the issues that have been faced by the Mental Health Trust, and that remains a key focus for us. We're in a second year of some important work helping to ensure the evolution and evaluation of community mental health care that is being done, well with those adults severely affected by mental illness and what happens with their carers. We also looked at the accessibility of the information you get when you go to hospitals like the James Paget Hospital. Groups of patients told us about their experiences, and we also focused on the language barriers faced by many who may struggle to communicate their symptoms and understand the treatment that they have been given. Hospitals, including the James Paget, said they are doing a lot of work around this, but readily agree that more needs to be done. NHS health checks, who are represented here today, were also something we looked into. The free checks for those aged 40 plus can help detect the risks of contracting a number of conditions, and more importantly, what to do next, whether it is a referral, lifestyle advice, or support with things like losing weight. Valuable work indeed, and we were asked to produce constructive suggestions for that based on what people having the checks have told us. The report's actually currently available on our website and is being used by Public Health moving forwards. As Patrick's already mentioned, we also visit as much of the area as we can. We're a team of about 19, not all full-time. Our engagement team, including Dan, who is here today and who looks after this area. I can't see where you are, Dan, but if you want to stand up, oh, he's waving at the back there. We visit as many places as we can, as well as ongoing work with the James Paget, surgeries and pharmacies. We also visit libraries, community centres, and events like, for example, the Galston Clifftop Festival, so we can reach as many people as possible. In a moment, you will get early sight of a video we're going to show at our annual general meeting in a few weeks, which recaps the work we have done over the last financial year. Looking ahead, though, we have a lot more work planned. We're due to publish a report on a major project we've been working on for over a year, called My Views Matter, which saw us visiting a number of care homes for people with learning disabilities and autism to find out their experiences as residents, their loved ones and staff following the tragic incidents of the Causton Park care home, which have been well documented. We're about to start a major piece of work, which is a first for any Healthwatch in the country. We're spending a week at each of the county's hospitals, including the James Paget. I think we're there on about the 19th of June, thereabouts. And the purpose of these visits is to gather lots of feedback and information about the experiences of patients, their loved ones, and the staff. Staff play an integral role in any feedback we receive because frequently as frontline providers, they have got ideas that don't always get heard where perhaps they should be. A report will be published after each visit explaining what we have found, as well as looking at any key themes that emerge across all three hospitals, and this will be presented back to both the Integrated Care Board and the Urgent and Emergency Care Board of the ICB. The hard work continues, and as promised, an update on some of the things we've been working on. Now, ahead of our first guest speaker, please let us look back at the 12 months of Healthwatch
Norfolk. Bringing health and social care together. The new system overseeing both aims to do this and ensure there's a closer working relationship, which should mean better care and support for all of us. Healthwatch Norfolk's statutory role is to ensure the voice of the patient is at the core of this, taking your views, ensuring they're passed to those who make the decisions and, when necessary, holding bosses to account. We've done that this year. Dentistry and the difficulty of getting NHS non-emergency care made up just over half of all our inquiries. We ensured the breadth of concern was reported to health leaders on a local, regional and national level, including sharing it with the government's Health Select Committee. This remains a priority for us, and we'll be ensuring progress is made on dealing with this huge gap in care, now that responsibility for dentistry rests at a local level. The future of the Norwich Walk-in Centre was also a major worry for many. While we accept that services need to be renewed and revised regularly, we highlighted flaws in the way the consultation was carried out, a view supported by the local community and many of those working within healthcare. Indeed, the walk-in centre was something we did some work on ourselves during the year, talking to patients and understanding what worked well and what could be improved. Around 250 people a day use it, and we discovered a need for more clinics, better communication about its work, and improved partnerships with GPs to share records and therefore enhance treatment. Better communication has been a key thread of what we've been finding out. We worked with the Queen Elizabeth Hospital in Kings Lynn to help them enhance the way they communicate with their communities, whether around appointments or future developments at the site. We also contacted all the health trusts with responsibility for Norfolk to find out about the efforts they make to ensure their communications are accessible. The results varied, some doing a lot of work on it already, while others saying there were still improvements to make. Our engagement also revealed there was work to do around translation for those patients who didn't speak English. The NHS is promising all patients better digital access to care by the end of 2024 for those who want it. We asked patients and healthcare professionals about their experiences so far, and the findings included clearer information about the digital systems out there, better promotion of them, and also tidying up the footfall system to make it clearer for those practices who use it. We completed the first 12 months of a 3-year programme to evaluate the transformation of community mental health. 5 different groups of people were engaged with, including adults severely affected by mental illness, their carers and support staff, voluntary organisations and care employees. Among the initial outcomes were people wanting to see greater trust, continuity around their care, and making sure carers are part of these discussions as well so they can give appropriate support. Where things are working well, they need to be communicated better, and there was also a feeling that more involvement in shaping services was needed from the voluntary sector. Ways of preventing people in Norfolk needing health and social care were also investigated. We found a number of ways of helping with this, including the use of technology, more being done in the workplace around health and social care, making sure that messaging from health and social care is consistent and not just about pressures, and also to start prevention work at a young age. People with pressure ulcers and lower leg wounds and their carers took part in a series of interviews to find out about their experiences of care. We found better training and communication was needed, as well as a greater availability of knowledge and information about these conditions. We also evaluated the pilot Waiting Well project, which supports people waiting for orthopaedic surgery in parts of Norfolk, with help like home adaptations, physiotherapy and well-being support. The project got a mixed response, and we suggested more communication about it, including information leaflets and a follow-up process to ensure the Waiting Well support was received. And we worked with patient participation groups to find out what extra help they needed to support practices and help to be their face in the community. A number of recommendations were given to the Norfolk and Waveney ICB, which asked for the study, around extra help, including more communication, recognition of the role of PPGs, and a mechanism for recommendations they make to be taken forward. Our engagement team have been very busy. They've carried out at least 130 visits to GPs, dentists, pharmacies, libraries, community centres and major events to hear about people's experiences of health and social care. Talking to people face to face remains absolutely vital to ensure we're getting rich feedback about the care and support people are getting. The team also carried out a piece of targeted engagement at GP practices, visiting 50 across Norfolk. This gained an idea of the challenges being faced, and we published recommendations to improve things, including shorter waits on phones, the opportunity to share best practice between surgeries, and better communication and information sharing. Our signposting service remained busy. We helped over 500 people with information, advice and support if they needed it with any aspect of health and social care. In addition, we received 2,649 reviews on our website about different providers. We also created digital information about a number of different subjects, including the progress of the Shared Care Records scheme, which means people across different hospitals and care settings have access to your information so you don't have to keep repeating yourself. The toolkit for PPGs, fire safety advice, information for carers, and a behind-the-scenes look at a pharmacy to understand the process from prescription to getting medication. This work doesn't stop there. We're compiling a report on pharmacies and your feedback, finding out what help's available for carers of patients admitted to hospital with dementia, and finding out whether those aged 65 and over in care homes know how to give feedback. Details will also emerge soon about a major piece of engagement work which will see our team spend a week each at the Norfolk and Norwich University Hospital, James Paget University Hospital and Queen Elizabeth Hospital in Kings Lynn, talking to patients and staff about their experiences. Even though we're anticipating another busy 12 months, we still urge you to leave your feedback with us and share your experiences, face-to-face, by phone or online. We are here to listen and share your views with those shaping care across health and social care.
I think you'll agree that's been a very busy 12 months, probably the busiest in Healthwatch Norfolk's 10-year history, and I congratulate and thank everybody who's played a part in making such valuable contribution to health and social care in the community. Well, we've talked already about the James Paget University Hospital, and we already know that there are plans for a new hospital in the next 10 years. Construction's already underway on a concept ward, which will give a blueprint of how care will be given in the new building. And it is being developed based on the views of those who will work in it and those of us who may need treatment there. To give you more of an insight and to answer your questions from the hospital, I'm delighted to introduce Mark Flynn, Director of Strategic Projects, and Diane Goodwin, Operations Director for the James Paget's new hospital program. Thank you.
Well, good morning, everybody, and thank you firstly to Healthwatch Norfolk for allowing us to talk to you all today about our really exciting new ideas that we have that are currently being built, actually. So, yeah, really good. So, firstly, really just to say, wanted to talk through our journey from our decant ward, which was seen as a bit of a negative thing to start with, towards our concept ward for our new hospital. So on the next slide, we share with you an artist's impression of the new layout, which is really, really positive. So just to give you, on the next slide, the background and brief. So we felt it was really essential to create a new suitable area for the Trust to decant its existing wards and other clinical areas to be able to progress with our RAC panel failsafe. Now, we use a lot of acronyms and jargon in the NHS, so I would welcome any questions that arise as we do talk through these slides, myself and Diane. So, you know, please don't be shy to ask questions because there's lots of jargon in here. So, really, RAC is simply really a lightweight concrete construction, and it's known to be defective, and there have been issues with other hospitals, but also within the education sector. But actually, we are in the process of mitigating the effects of that over the next few years, and we have external structural engineers that support us at the hospital with this really important work. So we knew it was essential for us to have some decant space, but we decided as a hospital to challenge ourselves not once but twice further. So to really ensure that the design of the ward could be part of the new and permanent buildings as part of our new master plan for our new estate, and to really make sure that the investment that we attracted wouldn't be duplicated with the new hospital that we knew was coming a few years down the line. And the other area that we challenged ourselves on was around research, to really support national thinking about the future of ward design through the National New Hospital Programme. On the next slide, and again, massive thanks to colleagues and people that have been involved in this, particularly from Healthwatch Norfolk, and Dan, who earlier waved at the back there, was really about the engagement and co-design that we've put together to really try to make sure that we've got patients' views involved in the design. And we think we've done a good job on that, but obviously you will be you'll be the judge of that. But in terms of the teams that were involved, our estates and planning team at the hospital, we also involved our architects from Health Spaces, who are the contractor that we selected to build the space. Our new hospital programme team, of which Diane is a key member. Also our clinical teams as well, and making sure that what is right for patients is also right for staff. We also had feedback from our engagement that we did last year on our new hospital, and I think we received over 200 individual comments back from individuals, both staff, patients, stakeholders, anybody that wanted to have their voice heard. We also had input from the National New Hospital team, and this was really invaluable as well. And equally, we had great support from our regional and national NHS England colleagues through reinforced planks. So on the next slide, we talk slightly about the location and planning considerations that we considered with this. So we wanted to make sure that whatever we built was going to be in line with our current strategy, but also our future master plan, and wanted to make sure that we had that thinking really clearly embedded with our new hospital and make sure that we could retain this new building. In addition, we knew that we've had other developments that we're already starting to plan and that are coming very soon as well. So that's our diagnostic centre, and we've also put in an additional business case for a proposed elective hub to try and make sure that we can recover and improve on our elective services for the benefit of patients. We also needed to make sure that there was a connection to the current building, and at the same time we wanted to upgrade some of our infrastructure, so that includes some of our power supplies and medical gases. The other thing that we were aware of was land use, and we knew that as a result of this we would temporarily lose some car parking spaces, and we are aware that that is still a current problem on the site, and we are trying rapidly to improve that. And we've made some steps already on that, but we know we've got further to go, and we're going to continue to work on that. On the next slide, we've got a graphical representation of how all of these things are going to fit together to try and graphically represent all of the key buildings. So the building in white there is the proposed Diagnostic Assessment Centre, or DAC building. The yellow building is the future cold elective hub, and the grey sort of building to the top right area is the concept ward, which is currently under construction. And the pink building is the connection to all of those buildings, so that we can make sure that this thing is permanent for our future. On the next slide, we talk about layout options that we explored for our new ward, and we had several options open to us. We could have gone for the traditional approach, which would have been simply 4-bedded bays with a few side rooms. But actually we felt on balance that probably didn't move us further forward in line with some of the national expectations. We looked at a hybrid option as well, with sort of a mixture of specialist side rooms and individual 4-bedded bays. We also then had some conversations with the National New Hospital, and we looked at the new expected guidance. We did get a sneak peek of some of that. And actually we know that the national direction now, and it's been announced publicly, that the national direction is going to move to 100% single rooms, which gives us real benefits on one hand, but it gives us challenges on the other. So I think there's more work that we need to do around that. And then finally, just in terms of where we landed, we ended up with a revised hybrid proposal. But I'm now going to hand over to Diane, who has been instrumental in helping with this design and really tying that together with our operational and other colleagues. So Diane, I'll hand over to you now for a few moments. Thank you.
Mark. So as Mark said, the preferred option that we went with for the concept ward was this hybrid, but with a large percentage of single rooms, so that we could test out those new ways of working. But we've still retained 2 4-bedded bays, so that will help with the research, so that we can compare the two. And whilst these are 4-bedded bays that are similar to what we've got in the current hospital, they will be to new size standards, so they will be much enhanced from what we've currently got. Sorry, I'm just checking the slide to make sure we've covered everything. Yeah, so the footprint, the other reason for the 4-bedded bays was that it does make the footprint of the decant ward or the concept ward slightly smaller, and that helped us fit it into the site that we needed to fit it into, and it also affected the affordability of the project as well. We have built into it the potential to upgrade, because this is a building that will run alongside the new hospital and have a new function after we've done all of the decanting for the rack works. So the 2 4-bedded bays can be converted into single rooms with en-suites, and we can in fact add on to the end of it to replace those beds that we would lose from doing that conversion. So we have future-proofed it from that point of view as well. So if we just move on to the next slide, and there's a diagram on this slide to show you the sort of view from the top down of the concept ward. And if you follow it through from the sort of bottom left-hand side, you'll see sort of the white corridor, and that's the link corridor into the current hospital. And then as you arrive in the ward, there's a small reception area, and there's some staff facilities. We've taken staff wellbeing very seriously with this development, because that was one of the areas that became really evident as lacking in our hospital through the COVID pandemic. So places for staff to change and to shower, and rest facilities away from being patient-facing, so that they could properly switch off for a little bit of time. So there's some of those facilities at the entrance to the hospital there, entrance to the ward, sorry. So the ward is arranged in 3 blocks, because it is quite a long, thin structure. So the first block of 10 single rooms, and you'll see that they're all en-suite rooms, and they've all got windows, so that patients and their visitors and the staff have views outside for well-being purposes. And then if you follow it along the top, I'm sorry I haven't got a pointer, there's sort of 2 larger squares in the middle, and that's the 2 4-bedded bays. So they're centrally located. We haven't got a sort of a large nurse station in this ward, as there would be in a traditional ward. The nurses will be dispersed across the ward in the different areas, but there is a very small nurse station in that central area there, and more support facilities, the sort of darker grey and the orangey bits, more support facilities behind there. We've got equipment storage, we've got a dedicated pharmacy, so all the things that are lacking currently in our ward, we've been fortunate enough to be able to put into this ward. So then you've got, if you're moving to the right, you've got the second block of 10 single rooms, and you'll notice the 2 at the far right are slightly different, slightly bigger. These have got anti-rooms with them, so they're geared up for full infection control purposes, if we need to use it for that type of patient. So the whole concept of this is that every specialty that we've got in the hospital now would be able to use this ward in a safe and optimal way. So that's why we've built in these extra measures. And then the ward ends with the sort of darker colour on the right, which is again more support facilities. So fortunately, we've got 2 sluices at both ends. This is where we process the waste, so we're not carrying things right the way through the ward. So that's another improvement that we've been able to put in, and really good equipment storage. So staff won't be needing to go off to distant equipment stores. We know that uses up an awful lot of time. Going and looking for equipment, it will be there, it will be close by, and additionally there are some alcoves for dedicated equipment throughout the ward also. So we've addressed that, but we'll obviously get to test that out. And then the rather bland looking white box with the 2 circles at the bottom there will be our therapy garden, which there will be access both for staff and for patients to use that facility. So really featuring on the well-being and enabling people to get outside and have some fresh air there'll be a route through that will encourage patients to sort of start rehabilitating themselves ready for discharge. So if we just move on to the next slide, it's a 3D view of the concept ward, so it's pretty much the same as that I've just talked you through, but it just gives it a 3D view, so it just brings it to life a little bit more. So there's a couple more slides now talking about the innovations. I've probably mentioned quite a few of those already. The 10 side rooms, we've got 10 of the side rooms, or single rooms, sorry, that have got specialist levels of ventilation. So that would mean that a low-level ITU, critical care type patient could use those rooms. And then the other 4-bedded bays and the other 10 single rooms have all got really modern standards of ventilation to allow positive and negative pressure, which is, again, something that we learned in COVID, that we couldn't put the correct, it was hard to put the right ventilation into an old style hospital, so we put that into here. And a little bit more detail about supporting the ITU patients is a dual bed head, so these are the sort of panels that sit at the top of the patient bed where the oxygen comes out and the suction and those types of facilities. So to provide for a critical care type patient, you need 2 of those, so we've put that into some of these rooms as well. We've looked at digital solutions and what digital advancements can bring to this ward and how they can help us with the concept of trying to have more of a silent ward, so there's not alarms and buzzers going off all of the time, disturbing patients and affecting their well-being and their recovery. So we've got a new call bell system in, which is a silent system. It will, the patient triggers the alarm or the call, and the healthcare provider will get that on a device, and it will tell them which patient, which room, and then they can contact the patient and help them in that way. So a more advanced digital offering, and we've actually built in more infrastructure into the ward than we can use at the moment, but we know that the future is becoming more digital, and so that we can locate devices, locate people. So we built that into the infrastructure so we wouldn't be ripping out walls and things at a later stage, so that we could put in the future digital innovations. So a little bit of future proofing. And the equipment library I've already mentioned with the equipment storage. And then on the next slide, a few more points about the innovations. Mood lighting, this is something I was really keen on, because we know we're going to have children in this ward as well as adults. We're going to have people with neurodiverse conditions, and the colour of the room, the colour of the lighting can be really beneficial or detrimental, accordingly. So we've managed to get the funding for mood lighting so that the patient can control the colour of the lighting in the room. I've talked already about the touchdown bases for the nurses, and you'll see that better on the slides coming up with the pictures. This is constructed with modern methods of construction, and it is anticipated to have a 50-year lifespan in keeping with the new hospital. So that means that this building will have good future use and should live with the sort of similar timeline to the new hospital. The BREEAM Excellence Standard, this is all around sustainability and net zero carbon, so we're very much needing to meet those standards. I mentioned about the wellbeing garden already, and then the layout that says side room, the single room, the patient room, we've put a lot of effort into getting that correct, talking to the national team so that we are designing the single room in the most optimum way, and again you'll see that better on the next couple of slides. So the next slide is the single room. So you'll see that the patient is orientated on the same side as the ensuite, the sort of cupboard in the corner with the chamfer on it, is where the ensuite is located. And the idea of the chamfer, the angled, is so that there is a view from the patient laid in bed out to the window, so that they can have that outside view for well-being, as well as it sort of becomes a seat for their visitors. We've got a sink in every room, and then the light will be it's sort of located above the bed, but I think it will illuminate the whole room for the purposes of the well-being for the different colours. So I don't know if any of you have been in the James Paget and seen the current bed space that we've got and can appreciate just how much better this new space is. We're really looking forward to seeing it and nursing our patients in this area. And the same with the 4-bedded bay on the next slide. With this picture, hopefully you can see that the space is bigger. I mean, we are putting in some privacy shields between the bays, between the beds, with windows in, so there's still that view out to the garden. There's a nurse's station within this bay as well, so there's immediate help and visibility. And we've got 1 ensuite and 1 toilet, so not exactly 1 bathroom per patient, but a huge improvement on what the current facilities are. And on the next page is the view of the touchdown base. So these corridors are much wider than the current corridors in the hospitals because of the modern standards, and that allows this space for a sort of computer and a desk for staff to use, so they can sit and have visibility of 2 patients in single rooms ahead of them, and if they turn around there'll be a view of 2 behind. So this is to help the staff adjust from being in bays where they can see patients, much easier visibility, and that nervousness about how do we still keep our patients safe in single rooms. So that's the solution that we're working with, and we'll get to test that out. And then finally, there's a really nice, on the next page, graphic of the garden design, and we put in an area in there. Obviously, we're hoping most patients will be able to, and staff will be able to walk or be wheeled around, but if they are restricted to bed, if we're talking about a critical care patient, there will be an area with a cover over it, which has got an oxygen supply to enable those patients to also get outside and enjoy the outside of the garden. I think it's over to you, Mark. Sorry.
Thank you, Diane. Last few slides you'll be pleased to hear. So yeah, just penultimately then, just in terms of the engagement that we've completed with this, with patients, communities and staff, we have worked with Healthwatch Norfolk on a joint project to engage specifically on the day room and garden spaces in the concept ward. We have engaged with people who've been cared for at the James Paget and also in single rooms at Carlton Court in Lowestoft. Feedback also gathered through online surveys and face-to-face structured conversations with inpatients, and also then detailed feedback being used in the development of the shared day room and garden spaces. And again, we would just like to continue to encourage people to get engaged and involved in this, because this is just the start from a James Paget perspective, and the future really does look bright. And we've got a lot of work to do in the next few years to get new hospital up and running, but the better the engagement we have and the more input we've got from public, patients, visitors, everybody, the better the end outcome will be for patients. So I really do encourage everyone to get involved. Just finally from me then on this, the programme timeline here on the next slide just shows just how quickly we've been able to pull this together. So the funding was announced in February of 2022, so just over a year ago, and actually it's almost built, this building, so that's how fast this is going to go. And I'm personally, I'm really encouraged and amazed at the speed at which we've been able to achieve so much. So I think that's really encouraging for the future. So then just a couple of slides then on the new hospital programme. On the next slide, I've showed a clear track here. So we've got an outline here in purple, a purple box, which shows the kind of current area that we're currently looking at with the concept ward, the diagnostic assessment centre, and the elective hub. And what we have here is an illustration of what the new hospital could look like on some adjacent land to the rear of or west of the current James Paget Hospital, which is shown in a sort of a light red dotted line there, which is the current site. We are obviously still working up various different options on new hospital, but we've engaged quite widely. We've got some of our corridors lined with some of these pictures already, so there's nothing new in here, but I just thought it was helpful just to show exactly which part of the site we were talking about today, but also linking that through to how it's going to work going forwards. And then finally, just in terms of the programme plan on the final slide, Just to show a bit here about the expected, as it stands at the moment at least, programme timelines for new hospital. So with all things going well, we're through the first hurdle of business case process, and we're now at the stage of what's called the outline business case. We then need to move to planning and then full business case. We then need to do things around legal commercials, so that's selecting a main contractor. Then we start potentially construction, potentially we're thinking as early as July 2025. We've left a very long construction period in there, just in the event that it takes us slightly longer to plan the building and make sure that we've got that wider engagement from everybody. But we're hoping to migrate to the site and be in by the end of March 2030. So that just gives you an indication of the timelines that we're working to at the current time. So that just leaves me to thank you for listening, and happy to take any questions which myself and Diane you may wish to ask. So happy to take any questions now if there are any. Stunned silence. Either it was very clear or it was very boring. I'm not quite sure which. But yeah, again, if there are any questions, please do get in touch. This isn't just your one and only opportunity. We want to have this as a continual discussion over the next few months and weeks and years. So please do get in touch. I know that there's contact details on our main website as well. And I know that Oliver Cruikshank, our Head of Communications, who's at the back in the room today, who's just put his hand up, also has a stand. So if there's anything that comes to mind, please do shout. But thank you.
Thank you, Mark. Thank you, Dan. That was very encouraging and hopefully very exciting for the future of the James Paget Hospital. I would just, are there any major hurdles that you need to get over, or is this actually now going to happen? I guess is my only question, really.
So in terms of new hospital, do you mean?
Yeah. Sorry, I get the microphone, but.
So, it's working now. Thank you. So yes, there are hurdles. So there are 3 parts to the business case process nationally. So we are one of 40 trusts that have been announced as part of the National New Hospital Programme. So we know it's happening. It's just a question of when and the timing of it, and that's the detail that we're currently working through with the National New Hospital Programme team. We are waiting and expecting some announcements, so we wait with bated breath, and hopefully at our next event I should be able to say a lot more about that, but hopefully that gives you an answer at this point.
Thank you very much. That's very good. Good news. Thank you very much indeed. I'm sure that if anybody has any one-to-one questions, you can nobble Mark or Diane as they leave afterwards. But thank you very much indeed for coming along today and giving us such a thorough presentation. Let's move on to talking about role of unpaid carers. It's something that none of us can take for granted. The emotional support, the close emotional support, provides vital help for those that they're close to, often family members or close friends. But who cares for the carer, ensuring their health and well-being? In the Great Yarmouth area, there are carer support nurses who can come up with a plan to help. Karen Murphy joins us now from East Coast Community Healthcare to tell us a little bit more. Karen. Thank you.
Just check my clock. Good afternoon. I'm Karen Murphy, and thank you for the opportunity to speak today. And I want to basically introduce a carer support role, which is a new role where we're thinking more about carers. A little bit of background information. The idea came initially from Professor Morag at the University of East Anglia, and it was grounded in the extensive literature on health and wellbeing impacts of the caring role on unpaid family carers. Morag established a research team from academia and national policy leads, and she conducted extensive stakeholder work before securing funding for the carer support nurse role from the former Norfolk and Waveney CCG and from Health Education England for its evaluation. a set-up group at East Coast Community Healthcare, then worked with MORAG to operationalise the role around evidence-based design principles, including delivery of person-centred care to carers with complex needs. The next slide, please. So what is a carer support nurse? It's a community nurse with that experience and skill to support the carers. It's designed to help those unpaid carers who have their own health and wellbeing needs and to provide opportunities for carers to talk to a professional who understands that complexity of caring. The stakeholders felt that this was a nursing role, as nurses have the knowledge and expertise to support carers' health-related needs, particularly when they are complex. Next slide, please. So who is the service for? It's for unpaid carers who are having difficulty maintaining their own health and well-being in order to support the people they care for. So this current pilot is covering Great Yarmouth and Northern Villages only and is running for 12 months. So carers and patients said that a carer support nurse would increase the likelihood of carers' health-related support needs being identified and therefore addressed by giving them permission to express them. Stakeholders have called the carer support nurse the missing part of the puzzle, saying that at last there is a nurse to support carers. And one carer interviewed for the evaluation described that just having the existence of that role to support them and knowing there was a healthcare professional dedicated to that was very positive and had an impact in itself. Referrals can be made from health, social care and the voluntary sector as well as directly from carers themselves. Next slide, please. So the support that I could give or we could give will include practical advice and training in order to help them in that caring role, such as managing medication, moving and handling, pressure ulcer prevention and providing personal care. Information and advice on other services available to support the carer in their role and advice and information to help them plan for the future. We can include general health assessments such as blood pressure checks and referrals for health checks and screening, and also crisis prevention and reduced hospital admissions for the person that is cared for. It's really important to express that the service is very much led by the individual needs of the carer and what they identify. Carers often express that they were excluded in planning for provision of care for their loved ones, particularly following hospital admission or life-changing events or a life-changing diagnosis. They were not consulted, offered training or support to enable them to provide care. There's also a majority of people in this position who don't even recognise that their relationship has evolved into one of a carer, rather than husband, wife, son, daughter, or even friend or neighbour. And they felt that it was just assumed that they would manage, or it was perceived as their duty to fulfil this role. And this is a red flag for carer breakdown, as the carer is not equipped to manage, is unable to cope, and they then become unwell, either mentally, physically, or both, and can find themselves in a crisis situation. I am aware of a carer who has left the house, locked the doors, and taken themselves to the police station because they did not know what to do. Next slide, please. The outcome of a recent GP survey across Norfolk and Waveney identified that 18% of unpaid carers were providing 50 hours or more of care per week. 49% of these carers are over 55. This is 4% higher in our area than the national average. If we just consider the 80% of people who live in the community with dementia, in the UK, it's estimated that over 500,000 family and friends act as primary unpaid carers for them. This saves the economy £13.9 billion a year, so we need to look after our unpaid carers. Next slide, please. There are risks to carers' health. They neglect their own health and well-being in order to cope with the demands of their daily routines. There can be a negative impact to their physical health, and they underestimate the reality of their role as a carer. They're likely to experience anxiety and depression and can also feel socially isolated. With that in mind, in line with the National Carer Strategy, we have a duty of care to those who are providing care, as evidence suggests that they are at a higher risk of developing their own long-term health conditions and subsequently have a lower mortality rate. Next slide, please. As seen here locally in Norfolk and Waveney, 63% of carers also have their long-term health conditions, disabilities or illnesses to deal with. 18% are experiencing social isolation, 18% have long-term mental health conditions. These are all along the side of dealing with their carer role. Only 38% of carers in the area felt that they were supported to manage their own condition by a healthcare professional. Next slide, please. So carers in Great Yarmouth have told us they often feel that their needs are not met, but instead feel assumptions are made about how they are coping. They may be supporting more than one person. They may be at risk of injury. Those assumptions about how they're coping or their ability to cope is taken for granted, and they feel abandoned or passed around by health and social care professionals. They often feel unappreciated and overlooked, and this also has an impact on their employment and income. Next slide, please. So a carer support nurse can offer these carers space for their own needs to be discussed, an opportunity to talk to professionals who understand how difficult it can be, for them to open up about their own needs, and time to support those carers to identify those needs. Because most of our carers want to continue caring, but the current healthcare provision doesn't work for most carers' health-related needs. Healthcare roles for both patients and carers prioritise the patient, leaving those carers' health-related needs largely invisible, unvalidated and also unmet. The carer support nurse role seeks to address this, help reduce the crisis and associated patient and service impacts through a carer-dedicated delivery of nursing knowledge and expertise to support those carers and to keep those healthy and looked after. Last slide. Thank you once again for the opportunity to speak. I have brought some information leaflets with me, including guidance as to how to refer to the service, and I'm more than happy to discuss further if you'd like to leave me your email address or have a chat at the end of the event, and we can maybe meet again in person. Thank you very much. Thank you.
Just making sure that Karen made it safely down the stairs, because I have to say it's slightly unnerving standing up here, because the stage is actually on a very slight slope so that you can see the chorus line at the back without having to look over the top of the people in front. And there is no light at all on the steps. So negotiating the stairs, well done, Karen. Thank you very much indeed. But also particularly thank you for telling us about this very important work for such an invaluable group in society that look after loved ones. Thank you very much indeed. And we're going to talk some more about compassionate care as well, and something else to do with the University of East Anglia. We mentioned earlier today about palliative and end-of-life care is always something very difficult to talk about. There is also much talk about the 95% rule. A person living at home with a life-threatening illness may only come into contact with statutory services for less than 5% of the day. What happens, you might ask, to the other 95% of the day? That's where the community comes in, and more specifically, compassionate communities. To tell us more, from the University of East Anglia, please welcome Dr. Guy Perrier.
No, I haven't thought this through. Can everyone hear me at the back? Can I just have a quick thumbs up? Wonderful. I've got a few transitions in my slides, and I can't see what you can see. So together, we'll get through it together, all right? So if I could start off, this approach is very much around trying to enable us to be more active in an area that we're not normally active in. If I could just give you a quick of a background. My grandmother was head matron in Lancaster General Hospital during the war and into the early 50s. She was a single mum and couldn't carry on in the matron role. So she rented a flat off a GP surgery, and she got referrals for people in the local community who were dying. And my mum grew up with 2 or 3 people dying in the house the whole time. And that was before the first hospice down in South London first opened. Why do I mention that? That's only about 70 years ago. And if you think how much has changed in that 70 years, in my opinion, we have over-medicalised death. Why have we done so? It's because we don't like to think about it. We don't like to talk about it. But as it's an obvious, it's, as Mark Twain says, there's 2 certainties in life. It's going to happen. Why is it a particular pinch point now? So in this first slide, hopefully you can see 3 main pillars of concern. We've got demand, workforce, and workload. We've got an ageing population. The people who are going to be in need of palliative and end-of-life care is set to increase between now and 2040. And we know that there are actually more people leaving statutory care services than joining. That's a complex issue that will be ongoing, but we do not have time to wait. In Norfolk especially, because of our geographical expanse, you have what's called opportunity costs. People in care services could be delivering amazing care. And by and large, they primarily do amazing care to a selection of families over here. But unfortunately, there may be even more families in a different area of Norfolk that are without care. So if I could move to the next slide. Patrick kindly talked about this idea of the 95% rule. I think it goes hand in hand what can be described as the circles of care model. And we're familiar with this idea of person-centered care. But for palliative and end-of-life care, the unit of care is broader than the person. It also includes the family and the people closest to them. So we need to think about, Richard, if you could click on a few advances to make sure that the arrows shows up. If we could think about trying to support the people that are closest to the person and their family, okay? So we're thinking about their inner support network, their outer support network, and then we get to the community and community groups. It's not until we go a little bit further out that we actually get services. So we need to think about, really, what are we doing to support the people that are closest to the person in need of care? So if we go on to the next slide, NHS England have formally adopted 6 ambition statements to try and improve care. And I work exclusively with number 6, which is entitled, Each Community is Prepared to Help. So entwined with that is around trying to spread public awareness to help, like as Karen was saying, how carers feel that they are supported with all the tools that they need to carry on the job that they're doing, because that's invaluable, but also to encourage more community action, which ideally is why I'm here today, is to highlight the need for change, but also highlight the need for change right now. So if I could move on to the next slide. Just one quick reflection on my experience of working with Each Community is Prepared to Help for about 5 years now. In my experience, there hasn't been a shortage of goodwill at a community level. So we need to flip it back to NHS and services and say, are services prepared to accept the help that's on offer from the community who do want to help? That's also an ongoing issue, because there is this problematic nature of being slightly risk averse. So hopefully what you can see now is a slide that describes the quintuple aim. Now, out in America, they have the Institute of Healthcare Improvement, and this started off with a triple aim, which, if I were to summarize, better outcomes, better use of resources, and better experience of receiving care. And rightly so, care professionals came back and said, well, what about us? So then they developed into a quadruple aim. So not only the experience of receiving care, but better experience of delivering care. And then more recently, especially in the wake of the pandemic, it's been broadened to a quintuple aim, which is trying to reduce the prevalence of healthcare inequalities. Now, if I were to bump it on, it's particularly imperative for 2023, as I've said, for the next sort of 20 or so years when we've got expanding demands. But compassionate communities is really centered on this idea of the experience of care. So always think about it at a human level, the care that we would like for ourselves and our family. It's no different. So if I could move on one slide. There was a Nobel Prize winner, he's a behavioral economist called Daniel Kahneman, and he wrote a book called Thinking Fast and Slow. I must confess, I didn't get to the end of it. It went over my head a little bit. However, I do remember this bit, and he talks about the peak end rule. And what is this? As humans, if we were to look back on an experience, we can generally bring two things to mind relatively easily. What it was like at its peak intensity, good or bad, but crucially, how it ended. My father-in-law died in November, and my father died in January. It's the memories of that ending that stay with me. Thankfully, both of them, because, I was in the know, I knew doctors, I knew nurses, I had tools at my disposal. However, is that the norm? Sadly not, but it could be. So on your table, I don't think I managed to get round everyone, but I've got spare copies, is something called the Compassionate Communities Civic Charter. And that's about how we can change the conversation in and amongst pretty much where everyone is. Next month, you may be familiar, there's an annual event called Dying Matters. And each year, there's a theme to Dying Matters. And this year, particularly important, is called Dying Matters at Work. How can we bring employers into the health and care network? I still find it a crying shame that if you experience a bereavement, you get 5 days statutory leave. If you need any more, you have to go to your GP and he needs to basically sign you off as medically unfit to work. I mean, really? Shocking, in my opinion. I've got 4 young kids, had 4 sets of paternity leave at a drop of a hat. And yet there's a lack of parity of esteem between birth and death. Why is that? So hopefully what you can see here is last year the Lancet Commission had an international collaboration and they called it looking into the value of death. And you can hopefully see 3 graphs that shows hospital admissions, primary care contacts, also outpatient care contacts, as well as healthcare costs. In those last 12 months of life, this is data for England actually, in those last 12 months of life you can see that steadily it increases. But look especially at that last month. If we're going to make a significant improvement around people's experiences, better outcomes, better use of resources, we need to think about what's happening in that last month. A lot of these people at home are pressing 999 because they're going through something that is new, novel. As an example, with my father, breathing changes, all right? To any nurse in the room, it's a surefire indicator that he's had a step change. He's actively dying. In his care plan, he wanted to be at home. But realistically, in any other situation, that would have triggered an admission. How could we potentially enable carers and people at home to recognize that these things do happen? Dying is a process like birth. We need to equip people to be aware of this. So if I could move on to the next slide, which talks about the importance of engagement. So we know that money is particularly, well, it's a pinch point. NHS services have got to cut their budgets by at least 30%. But what we can do is invite people in, offer a platform, to share our experiences and also collaborate on local approaches to better supporting each other. So if this captures anyone's interest, I'd love to speak to you more about it, because the future is about multi-agency collaboration. So if I could move on to the next slide. And historically, when we talked about sort of pilot schemes, often they drop off a cliff because funding is removed. Again, we don't have the luxury of this. We need to carry on moving in the right direction. And how do we do that? It's around documenting learning. So rather than trying to put barriers of pass or fail, this scheme didn't quite work out. There's learning in everything. Another way to frame it is there's no such thing as failure. There's success and learning. Learning what not to do is just as valuable as learning about what to do. So my last slide, if I had to summarize, money can't be a barrier to act. We need to invite members of the community in. We need to steward the reason for why we're meeting. Find out what interests people who have turned up, all right? It's not about doing two people, it's about doing it together, all right? And acknowledging that when it comes to end-of-life care, this is a shared responsibility. Services cannot maintain the level of experience that we would all want to. I'm a Thatcher baby for my sins, I'm sorry, all right? The market will not deliver what we were led to believe, okay? This is the truth. So, if I could just end on a 3-minute video, and that's about some work that went on down in Halesworth in the Pear Tree Centre. It's essentially a hospice without any beds. It's work we did working with the community charter, working with schools, and see what you think. I'd love to hear your thoughts.
You Googled it and wished you hadn't. So you don't mention it because it might disappear. Because you don't want to be a burden. So what next? Where do you go from here? You are not alone in this. Together, we can ease the stress, get you through the troubled nights, put your mind at rest. You could try the Pear Tree Centre. You'll be welcome. Step inside. There's always a coffee, a slice of cake. They've got the map. They'll be your guide. Maybe your daughter is 20 with cancer, or since your stroke you can't get about, or after the motorbike accident you've struggled. Take a deep breath, reach out. Feels like you're on your own caring for Dad, or since the surgery you've not left your flat. Let the volunteer centre send an isolation buster to share a cuppa, have a good chat. And if you go down to the woods today, round the campfire you might meet a new friend. Discover fresh energy with Tai Chi. Find a group you might attend, because we need to talk. Get the men's shed buzzing with banter. The conversations have just begun. At Crafty Chatter, we like to stitch and bitch. Together, we'll learn how to cook for one. And let's talk about your best death, so we don't have to guess how you want to go. Where to scatter the ashes, your wish list, your playlist. Get it off your chest so your loved ones all know. And anyone can help. Could you be the driver for her next appointment? A volunteer for the shopping he requires, a furniture shifter for the hospital bed, the good neighbour who'll light a gas fire. There's so many kind, helpful people who can brighten up the place. A friendly hand on your shoulder, a smile back on your face. Get yourself some peace of mind. There's no problem you can't share. So when you lay your head on the pillow, you'll know we are here.
Guy, thank you very much indeed. That was very powerful, and I can see that the video was very moving as well. Thank you very much indeed. And thank you to all of you for coming along today in what is one of a series of events to mark the first 10 years of Healthwatch Norfolk. Please do keep in touch with us, chat to the team here today and the many other organisations here today, and share your feedback and your experiences with us. Finally, talking of thank yous, we'd like to say thank you very much to the staff and volunteers here at the wonderful Pavilion Theatre in Galston, who've welcomed us today and looked after us so well. I think just a round of applause just to say thank you very much. And once again, a big thank you to all of you for coming along today and supporting the event as well. We really appreciate your time. Please get together, share your feedback, and have a bite to eat with us. Thank you very much indeed. Thank you.